All right.
So is the I just want to ask so is if the is the cerebral atrophy is correspond to the severity of symptom of Alzheimer's disease, is this corresponding or
Again, sorry.
She asking whether like for the severity of the cerebral atrophy responsible for the severity of the Alzheimer. Is it going like all
Yes.
together like with the Alzheimer? As the Alzheimer progressing, is that also there are also more damage with the brain? Is that what you're trying to say?
The Alzheimer, the cerebral atrophy. That's the severity of their two of things that go together. You mean?
Yeah.
I cannot tell now. Like, is it look like the research? But according to my knowledge, yes. The more atrophy of the cerebral tissue, the more severity of the Alzheimer's disease. Because the neural function become decreased. All right, a lot of question here. So you really care about the Alzheimer's disease. Hold on, the patient have about a BMD level, so this T-score minus 2.6. It means now they have to start the treatment for the osteoporosis. That's the values they need to start treatment with the medication.
So I guess I'm just gonna review what is going on with the patient now, or what is the next steps. Anyway, like we already know like this patient has Alzheimer. What about like the other symptoms, and anyone can tell me what about the other conditions that the patient is having? Like she
they don't know anything now.
No ideas?
Okay.
Like osteoporosis. What about the Dr. An? Do you remember that I was telling you about like the runny nose?
Yeah, what happens? I think that you said that you take allergy medication for your runny nose, but I don't remember what kind of medication.
Oh, it's one of the like antihistamine that I just like.
So and you said that after you take that medication, you feel so tired and want to sleep, right?
Yeah, exactly. I also like.
Since you asked about Alzheimer's disease, I think that I did read a bit about it before, but I don't remember well. Is the patient's urine incontinence might be related to Alzheimer's disease, and patient have memory loss and dysfunction of I don't remember well.
But yeah, it could be like the Alzheimer could also be responsible for the urinary incontinence. So Dr. Thương, what should I do next?
Go ahead. You are the host. You can do everything you want.
Yeah, I just gonna review like all the. So so can you tell me like what is the most the most severe like symptom that the patient is having now? Like what would you need to manage? Like you need to address right now?
I think that might be the postural hypertension, because the patient have a lot of underlying disease like atrial fibrillation. So she has high risk of stroke if she has hypertension.
No, she I think so she like I said she has like atrial fibrillation, but it's quite well controlled with the medication. Like it could of course the metoprolol could also can also the side effect with the hypotension, but do you think that what about her falling, like do you guys also need to take care of that, or like she also could
maybe she has some bone fracture, so I would like to order hip X-ray before.
Risk of falling due to postural hypertension. So Dr. Lick, right? Dr. Chun Lick. He's trying to say is the falling is like the secondary problem, right? So the primary problem that would be the postural hypotension, and also the low
Bone density.
Yeah.
density
Yeah.
is the primary problem. So I'm just gonna start with my presentation. This is like from the pharmacist field, so probably the doctor have like different approach. So all the diagnosis that you are managing is the Alzheimer's disease, her fall, which is I don't know, maybe because the Alzheimer, maybe of some of the medication that she was taking. Atrial fibrillation is on one of the chronic condition here, and unspecified urinary incontinence. She also has osteoporosis, allergic rhinitis, and if you just go back to for the lab test, you see the A1C here is 5.1%. So she is also pre-diabetic. And any question for that?
Mm-hmm.
Why you say that it is unspecified urinary incontinence? Because the patient says that she have not controlled her bladder all day, not only in the sleep duration. So why you said that it is unspecified urinary incontinence?
What I mean, like when unspecified is like we don't know what is the cause of the urinary incontinence. You think, like you said, like maybe because she has Alzheimer, but we haven't looked to her medication, so maybe there was something wrong with her prescription, or maybe there was also underlying, or maybe there was like a combination with the disease and the drug.
For better words, you can use here, if you think that this is, you don't know about the cause, you can go with the idiopathic.
Yeah, idiopathic, yeah.
Yeah, better. So because of you use unspecified, so make Dr. Ang feel like, yeah, I agree with her. So you cannot, we know about that, the symptoms. Yeah.
Thank you, Dr. Thun and Dr. So the drug therapy problem for this patient is, if we can go back to the prescription. So so can anyone tell me like what, like the list here, what's the warfarin? What is warfarin for?
So the warfarin were for the atrial fibrillation.
What does warfarin does with the atrial?
Anticoagulation.
Yeah,
Right?
yeah. This is anticoagulation, and alendronate is for her osteoporosis. Diphenhydramine is for her allergies. She also taking Tylenol for her pain, and metoprolol for atrial fibrillation. Donepezil 5 milligram for her Alzheimer, and recently, probably like a few weeks ago, she been taking ginkgo biloba to increase her memory. So this is yeah, I have to thank to Dr. Thun to remind me about antihistamine H1. So anyone tell me one of the side effects for antihistamine, the first generation for H1?
It make you feel asleep, feel tired and asleep.
Drowsy. You go with the name is drowsy.
Drowsy.
Good. So let's go back to the slide. Yeah. So the drug therapy problem for this patient is inappropriate use of the diphenhydramine. For elderly patients, like for allergies, for like allergic rhinitis, we have the guideline that we will take the Codius steroid, corticosteroid, like in the nose, like in an insurance. I'm sorry, I forgot the technical term for that. To manage the allergic rhinitis. And here we have also again, like there was an interaction between warfarin and ginkgo biloba, and this will increase the risk of bleeding for in the patients. It's also ginkgo biloba can also increase the tyrosine levels. Anyone has any question? Like Dr. answered before, like her fall could be her fall and orthostatic hypertension could be explained by taking diphenhydramine, but also could be because metoprolol, because of Alzheimer's dementia. So it's combination. Maybe it's a combination between the drugs and her conditions. So the INR for the patient with the non-valvular atrial fibrillation is like we need to maintain her INR in the range between 2 and 3, and here the INR is 3.1, which is just slightly above the target, the range that we need to. This could be explained by her taking ginkgo biloba. But so yeah, that would be explained. But anyway, even she doesn't take any ginkgo biloba with the INR 3.1 is quite normal for that. But we need to take care. So we need to remove the ginkgo biloba from her prescription. So now I'm gonna talk about like the drug classification that will be appropriate for managing patient signs symptoms. The first one, anticoagulations. So we're gonna continue warfarin and stop the ginkgo biloba. For the beta blockers, we continue metoprolol 50 milligram for the rate control of atrial fibrillation. For her bones, bisphosphonates, we continue the alendronate 70 milligram per day for as osteoporosis management. But we also need to probably combine with vitamin supplements, because also for her allergic rhinitis, we're gonna administer the corticosteroid intranasal fluticasone 1 or 2 sprays, and we will stop using diphenhydramine. And for her Alzheimer dementia, we just continue the dose, because we can increase the dose of donepezil up to 10 milligram, but be aware of the side effects such as like nausea or diarrhea. So maybe some patient will like refuse to take the medication to increase the dose, or change to like different kind of medications. So we need to take care of that. And vitamin, just like I said, like with the osteoporosis, we need to add calcium and vitamin supplement. Now, like a little bit, like a little background about warfarin. Why we need the warfarin on the patient with atrial fibrillations is because like on the patient with atrial AFib, like there will be a development, a subsequent embolization of atrial thrombi of non-valvular valvular or valvular atrial AFib, and so we will like make we will like count the score for the like the risk of thromboembolism. Here the patient we will follow the chart VAS score. With the patient which is greater or like equal to 2, then the patient is eligible to take oral anticoagulations. Here the patient is female, so the patient has one additional point, and also because her age is 87, so her score is 2, so we will recommend to take oral and anticoagulation. So like if you come back to the regimen, like the schedule for she taking medicine for the warfarin, you will see like different dose on different days, right? Anyone notice about that? Like on maybe like on Monday, Wednesday, Friday, on Sunday that would be 2 milligram, but on like the odd days on Tuesday, Thursday, and Saturday, that would be
Yes.
4 milligrams.
Yeah, it's to reduce the dose to the lowest as low as possible, right?
Yeah, to like it's kind of hard to maintain like a same dose every day because like because they also calculate by week. Like I haven't like I remember like there was like the maximum dose per week is 20 to 20 milligram per day. So if you can just like if you take like 3 milligrams like per day, that would be or like 20, let's say 20 milligram per week. Then maybe like if you can just take like 3 milligrams every day, or maybe like 2 or 3 milligrams. It is you need to like customize personalize the regimen of the dose on each of the individual patient. So that's the reason why there was like 2 milligram, and then the next one will be 4 milligrams, because in total that would be around like 20 or 22 milligrams. But here like we see like the INR is between 2 and 3. So like before taking the ginkgo biloba, so the regimen for the patient is I think is appropriate. For corticosteroids to control allergic rhinitis in older patients is a preferred treatment, and also continue to use diphenhydramine going to increase like the risk for and orthostatic hypertension. So we're gonna remove that. For bisphosphonates, here we're gonna look at the score, and we're gonna just like evaluate the risk of bone fractures for the patients. Like as you can see, the last bone mineral density score is minus 2.6, which indicates the osteoporosis, and she currently on the max dose of alendronate. So we need to so the next step that would be add vitamin D3 and calcium. As you can see, is the borderline. Sorry, there was a mistake here. The vitamin D level is 21 nanogram per deciliter. And for her Alzheimer, we can see there was like for the MME, she already her Alzheimer has already progressed to like the moderate with no like improvement. This is indicating moderate cognitive impairment. So we need to increase the donepezil to 10 milligrams. Because the initial dose is 5 milligrams, so we can just indicate to 10 milligrams, or we can also combine with different medications. But it depends on how the patient can comply with our indication, because sometimes it will they will experience a lot of side effects. But also because like the medication may not be able to improve her conditions, their conditions. So what are the important counseling patient education point to you with these drugs is, if you know about the alendronate, you need to know about like you have to, this is this like this could cause doctor, what is the name of the
Bisphosphonates.
No. I mean like the side effect if we just like
esophagitis.
Yeah, esophagitis. So you need to take a lot of plain water and sit upright after taking the medication for 30 minutes. But on this patient, because she has Alzheimer's, so she probably gonna need someone to watch over her. she probably just like forgetful and she just like take a medicine and then I feel tired, I'm gonna just like go to bed. So we need to watch out about that. Donepezil, it might cause the upset stomach, so it take with food, and of course we're not gonna use an NSAID on this patient because the risk of bleeding. For fluticasone for allergic rhinitis, we only use only needed and not as daily medications, and for no more than 3 consecutive days due to risk of rhinitis medicamentosus and rebound vasoconstriction. And for her pain, we can use iPads. This is like non-pharmacologic treatment on the injury for 5 to 10 minutes, 5 or 10 times a day, and avoid direct contact with the iPad. But Alzheimer's disease, like I said, we just increase donepezil to 10 milligrams. But we also need to some like intervention from the aid nurse or the family member to stay the patient during the day, because she probably gonna feel lonely, and she's gonna need to be take care of that. For her fall, like we could do like remove the rugs and install handrail for bathtub. Maybe like always keep the bathtub always like dry. Clean up the clutter. Make sure there was like a good lighting so she can see like everything clearly. And also maybe encourage the patient to use the cane or the walker, non-skid sock when out of bed. And also discontinue diphenhydramine. Atrial fibrillation, continue the metoprolol for rate control. For someone, if you would concern about the hypotension effect, we just need maybe recheck after we remove the diphenhydramine. If the patient still experience the hypotension, then we will maybe look for another cause. Maybe it's a metoprolol for the culprit for the hypotension. For urinary incontinence, so it could be it could be because dementia. So we can teach bladder control techniques and use briefs for incontinence. Osteoporosis, we just add calcium and vitamin D, and but remember to take alendronate 1 hour after consumption. In allergic rhinitis, fluticasone nasal spray, discontinue diphenhydramine. Pre-diabetes, we will encourage like a patient to have like a consistent carbohydrate control diet, and follow up the appointment after 1 month to evaluate safety and efficacy of the plan. So this will be the end of the presentation. So anyone has, I know it's a long presentation.
So everyone, are you still awake? Hello?
Yes, yes, I do. But it quite a lot of knowledge to put it in your head in one time. So maybe I will take it later after I receive the
soap note.
The PDF file you upload in the Facebook group. I will scrutinize them later, because it's so much knowledge.
S and F, what does it mean?
Sorry, where is that?
S and F.
I think it's nearly at the bottom of your presentations about some maybe.
I think so.
Go up.
You go up.
Bit. I think one more. S and F. What does it mean?
Where F and F?
About the Alzheimer's disease with
Possible for SMF replacement. Means skilled nursing facilities. Like you can use some like we can the cane, or kind of like something how the patient can become thin or
they will specialize on like the Alzheimer patient or whatever like condition the patient has. So they will be like to help the patient to rehabilitate with like after the fall. Does that make sense? It's a facility that could help the patient, because like this patient is she lives alone, she lives alone, and maybe she won't have anyone to take care of her except for her daughter. So she could be referred to the skilled nursing facilities.
Okay.
Yeah.
Yes. Okay. Thank you so much for Mr. Ang for your good, your lots of information about the medication, and I believe you guys will have more think about using medication in reality or even in treatment for the patient. But I want to ask you guys, do you guys catch up about what the problem for the patient until now? I mean, like have lots of right, but like actually this case just for the patient, the symptom of patients because of disease, their possible disease, this is kind of it's okay, but they get the side effect of the medication, and that's bring their her symptoms, and you can see like that about dizziness or about falling risk, and what else? Postural hypotension. Yes, and we guess not like not only for the disease like Dr. Mr. Ang can say here like about the Alzheimer can bring the risk of the fall or kind of like that, but it can be from the medication, and we have the list of medication here can bring the risk, but you need to classify which one for the symptoms. So we have like antihistamine, the first generation, that's bring the risk of the postural hypotension, and that's also the increased risk of fall, especially in elderly patient. And they give like we should not use that for elderly or for the patient who over than 65 years old. The warning or even like contraindication, should not use a first generation antihistamine for treat allergies in the patient who are older than 65 years old, because it's the increased risk of postural hypotension. That's the first one. The second one is about what else? Yes, she using metoprolol, right? That's a beta blocker. So that's also increased risk of the urinary incontinence. Besides what a medication can also increase risk of urinary incontinence? No, that can be like about antihistamine H1. That also increase the risk of the urinary incontinence, but we can one of them or both of them. So when we use like that, you need to pay attention to the symptom of the patient. And when we know that symptom because of the disease, or that's become because of the side effect or of the medication, how can we know that? In reality, when you do the clinical practice, how can you know? They can meet together. Doctors, how can you know?
Well, I am not a doctor, but I guess I would say
Okay. You will be a doctor in the future, don't worry.
no. Actually, my major is in nurse, but I guess
Wow, great.
compared to reality, the patient could have some symptoms because of medication side effect. When you asking about the history, like she just started some side symptoms after a period of time she using that medication, or it's just like this can change some like physical size because of medication, not because of her disease for a period of time. I guess.
So, where are you working now?
Well, actually, I working as a nurse at gastrointestinal clinic, and also a part time as a research assistant.
Oh,
Good
that's
job.
really nice. Wow. You have very good knowledge about medicine and also like have experience for working with a patient.
Thank
That's
you.
really nice. Yeah,
No, I don't have a lot of knowledge about the medication.
even you have the good
substance.
English as well. That's really nice. Wow.
Thank you very much.
Yeah,
You
it's,
can,
it's really
you can
nice.
keep studying. You can keep studying, become a doctor in the future, especially in the overseas or even in Vietnam. It depends on you if you want to.
Well, honestly, personally, I want to study higher education as in the major of global health or public health
Mhm.
because I think practice like based on like evidence-based
Okay,
practice
good.
is better, and there are a lot of problems now in medical like healthcare system in Vietnam also.
Good. Very nice. Yeah, I like it. I also love global medicine because like this, you need to treat the what we call for that. This is symptom or the disease as a system, and this has a big impact to community more than just the individual. Sometimes we need to do that. Thank you so much. And yes, to back our talk today, and when we want to know about that's a medication can bring the side effect, that's a symptom or the symptom of the disease of the patient based on the time frame. Like you need to ask them when this start, when the symptoms start. If the symptoms start before or even when they admit to the hospital or before they use medication, you cannot think that's because of medication. But after that, or even like it's very close the time when the patient start using that medication, you need to think that's maybe the side effect. Or even like at home, need to ask them before you use that medication, do you have that symptom or after you use that? All right, so the time frame very important for you to catch what the symptom because of the medication or not. So in this case, have lots of symptoms meet together. So that's difficult to you guys to differentiate that from disease or from the medication. But if you have the experience, like you have the experience for treatment of patient, you can recognize this, and you can look for about the time frame or even like about her symptom or her workup. Like everything's normal, but why the patient have symptoms, right? So it's also the question too. All right, so you guys have any question for the host today or for all of the SB here?
I want to ask about.
Okay, go ahead.
I want to ask about how can we consider the drawback, in other words, the side effect of corticosteroid when we switch from the antihistamine to the corticosteroid, because I think corticosteroid has various of side effects, like patient have been decreasing in the white blood cells, so it put patient in the higher risk of infection, and also the immune suppression.
Okay, hope Mr. Ang used the chest,
especially
corticosteroid.
Yeah, but like the intranasal steroid, which is used just like
nasal spray.
Yeah, just use the spray, and we'll limit the use only like maybe 2
as needed. As needed.
Yeah, as limit.
In this case, patient has Alzheimer's disease. So how do we assure that she can remember what time he uses before?
Yeah, that's a good question. So that's why we need someone to also, like I said before, we need to take care of like someone who need to like watch her about like monitor like her taking medicines. Yeah, so just like on this case, I only think of like maybe like just like someone on like with her 24, like not 24 hours, but 24 hours, but you have to assign someone to stay with her like most of the times, because she already has Alzheimer's. So not only this medication, but
yeah, I think this case has the better we can do for this patient, like for the treatment as well, should admit her to the nursing home.
Yeah.
because she's living alone and she have the Alzheimer's disease, and she also using a lot of medication, and also have the risk of falling. So want to make sure her safety. So we need to need to bring her to the nursing home better. That's also situation. Okay, for the corticosteroid, for me, kind of like it depends on symptoms. We don't know about the allergy symptom now, like is it severe or not. So should we need the corticosteroid or not? And for the using the
Steroid.
Yes, steroid.
The steroid.
Today I have problem. Okay, steroid sometimes for the nasal and like kind of with the it's not like oral and you take like as needed. It's also decrease the risk of, like you said, we can use it with the long-term steroid can increase the risk of the Cushing Cushing syndrome, and also make the adrenal atrophy. And this adrenal insufficiency, chronic adrenal insufficiency, and we're afraid about that. But for the spray, nasal spray kind of is okay, like better than so.
If we use the if we administer this patient with intranasal spray, so we can use long term of corticosteroid.
Should not use long term. Yeah, we're not.
Did you have to notice this is a seasonal allergies, rhinitis?
Because
we also have to maybe like we could do like a nasal.
Because I see in the presentation PDF that a patient just have seasonal rhinitis. So I think it's just before several days, a couple of days. So is this necessary to change our medication for just a short term disease?
For me, I would not change to corticosteroid. Actually, I will go with the antihistamine with the second generation. That's also in fact, but there's a degree rate. Second generation, we can go with that. And but corticosteroid also the option. Don't worry, that's also the option. It's not like that's the worst, but that's also the option in case the patient cannot relieve the symptoms or moderate to severe. You can start with the corticosteroid. Okay, so as I told you, it depends on severity of the patient. If you use with, I recommend use with the medication. But like it's not, you should not keep the first generation antihistamine here. Should not. Because as I told you, that's a warning and contraindication using for the patient who is older than 65 years old and also have the risk of hypertension. So postural hypertension. So I want to keep that.
Because since I as I remember from pharmacology subjects when I asked in the second and in the third year medical student, my teacher said that the first generation of antihistamine has a lot of side effects in comparison with the second generation. So why do you did not consider the second generation at the first line for this patient?
We don't know. That's a doctor's prescribed for her. How can we know? Like we not like go with the second generation first? You don't know. So we just revise about the past medication she's using, and then like current medication using, and looking for why this happened, and just we change. All right, so that's the last thing today. Thank you again, you guys, for patient with us until now to keep continue our talk. And that's a sixth lesson halfway. It's a case we discussed together. So we still have the 4 cases in next time. So hope to see you guys again, and we can discuss more or even practice more. Thank you, and have a nice weekend. And good night.
Good night. Thank you so much, Mr. An, for patient.
Okay.
No, you guys like the the one who is being patient.
Oh no, I'm really bad in
All right,
taking
thank you
medical
everyone.
history.
Don't need
I will
to
fall
say.
asleep, you know, it's like.
All right. See you next week. Next 2 weeks, sorry, next 2 weeks.
I will see you at the next 2 weeks, Dr. An.
Thank you.
Yeah.
See you
Bye
again.
everyone.
Yeah, good night. Anh An có ý kiến gì không? Mọi người thêm mọi người đi, mọi người nhận xét cho anh An không? Các bạn nhận xét trước đi tới anh An.
Xét anh An đó chị hay là nhận xét ai? Ồ, tụi anh ra nốt rồi.
Đang